Okay. I am also stepping in today for Dr. Joel Saltz, who is traveling. If you don't know me, I'm a research faculty member at Stony Brook University, and I've been involved with the N3C project from some of the early stages. So just a reminder for today, this presentation will be recorded and will be archived in the CD2H YouTube channel. And of course, and use your Q&A button to post your questions. Also use the raise hand feature for the host to unmute your microphone. And for anything else, please post in the chat section. Next slide. Okay, so this is just a view of the upcoming presentations. So the reminder, next week we have off for MLK Junior holiday, so no presentations. And then we come back on the 23rd for the C4R, which is another interesting cohort project for COVID. And then we hear on the 6th on the publications committee, and then on the 13th on PPRL, which is used to link records on the back end. Next slide. So one of the nice things about doing this is my second time guest hosting for the community forum is that I get to present how the N3C, the activity N3C is continuing. And as my role, I'm involved in the data ingestion and harmonization committee. And so I know that these numbers will grow, maybe not growing as much as they grew in 2020 in the rate, but they're still continue to grow and we still have continued activity. So we have a total of 77 sites, 17.4 million persons, 6.8 million COVID positive cases, and total number of rows, 21.8 billion. And I can go through the other numbers, but it's pretty, it's continuing to grow and continue to scale, and the number of very active research projects on it. And there's also a lot of somewhat interesting work always happening behind the scenes in terms of bringing in new data sources to link into the EHR data. Next slide. Okay, so we get to hear today from work within the N3C, and this is work that has had some good, has made a splash. And so we're going to hear from Dr. Justin Reese and Carolyn Bramante on how Metformin is associated with less severe COVID-19 and how this informed a phase 3 trial. So, always with EHR data, this is a great example of, and we'll hear about how, we can utilize EHR data to, inform clinical trials. So without much ado, we'll start on this. Thank you.
All right, I think I'm going to lead us off. So can you see my PowerPoint?
Yes. But not in presenter mode.
It is?
Now it is.
Okay. Great. So thanks so much for having me. I'm really excited to talk about both observational analyses in the N3C as well as a phase 3 clinical trial that was going on in parallel, and the two were informing each other. The trial itself was funded by donations of exact matching placebo for fluvoxamine and ivermectin. The trial that I'll be talking about was funded by foundations, Parsons, Rainwater, Fast Grants, and United Health Group Foundation. Much of my time was funded by the KL2 and then K23 from NIDDK. I have no personal financial disclosures, and I will be discussing off-label use of medications. So the reason that I got involved in studying metformin as a potential treatment for COVID started with in silico modeling. So David Odie is a biomedical engineer here at the University of Minnesota, and he has a large computer simulator. And normally he and his team study cancer cells and find proteins for novel cancer therapeutics. And they've recently earned a $9 million grant from NCI. So their simulator has proven itself in that area. And in early 2020, they developed a simulator of SARS-CoV-2 and identified drug or proteins that seemed particularly important for the viral life cycle. And then other researchers here at the university, Chris and others, used natural language processing to identify medications that were active against those protein targets, one of which was mTOR, and metformin is an existing generic medication that inhibits mTOR. And so I got pulled in after this to help with an observational analysis in United Health Group data very early in 2020 before N3C was up and running. But as the course of 2020 went on, the simulator predictions of other medications it made for COVID ended up being correct over and over again. When looking into the history of metformin, it actually has a history of antiviral activities. The oldest publications that I could find on metformin actually had to do with influenza and improved outcomes related to influenza. Metformin fell out of favor for a period of time after those initial papers because other biguanides had safety issues, but not metformin. Then it was FDA approved in the 90s for treating diabetes. As people had been on it for years and years, there were some cohort analyses suggesting anti-cancer benefits. And then in the 2010s, there were in vitro assays of metformin against other RNA viruses like Zika virus. And it is currently being used in a few other infectious disease randomized clinical trials. But also early in 2020, metformin was one of the medications that was tested by a group at UCSF. They tested a large number of medications, as you can see, and they identified that inhibitors of mRNA translation was an important susceptible part of the viral life cycle. So that's similar to what David Odie predicted with his simulator. And you can see here, metformin was one of the few medications that decreased the viral growth and actually improved cell viability. In addition to anti-viral actions of metformin, I came at it from previously being involved in the diabetes and obesity research world, and papers had always been coming out about metformin having anti-inflammatory actions, and many of these anti-inflammatory actions appeared relevant to the COVID-19 pathophysiology. And early in 2020, there were a few observational studies coming out suggesting that there was an association between pre-infection use of metformin and decreased severity of COVID-19. And one of the earliest papers even suggested that metformin users had lower IL-6 than similar individuals not on metformin. And that would be observational data to suggest that this pathway is relevant and working as hypothesized. But observational data are never perfect and they're always susceptible to residual confounding. So that was one exciting aspect of the N3C database, is because it had enough individuals in various groups to make it possible to do some of the more rigorous approaches to pharmacoepidemiology observational analyses. So what we did in our first metformin paper in the N3C was to try to reduce that residual confounding by using a prevalent user design of therapeutic equivalence in adults with type 2 diabetes. So we wanted to compare individuals who were only taking metformin for their diabetes to individuals who were only taking sulfonylureas for their diabetes to individuals who are only taking DPP-4 inhibitors for their diabetes. And what we came up with, so this was done, this was the data set that we used at the time. This paper was submitted for publication in summer 2021. And despite starting with over 1 million individuals, by the time we applied the appropriate exclusion criteria, we were down to only 450 DPP-4 inhibitor users, 905,000 metformin users. So the results of this analysis show, this is table 1. Again, everyone in this cohort had type 2 diabetes. There were no obvious differences in the groups at baseline. And this figure shows the standardized mean difference for variables, comparing the two groups. On the left is metformin versus DPP-4 inhibitor users, and metformin versus sulfonylurea users. The green are after weighting, and the pink are before weighting. And you can see that for both cohort comparisons, the weighting did a really good job bringing the standardized mean difference down to a very small number. And what we found was, after setting up the cohorts and conducting the analysis, similar to enrolling and randomizing in a trial, was the following associations with less severe COVID-19 hospitalization, ventilation, and mortality. And you can see that all the dots are to the left of a relative risk of 1. There are hypotheses that DPP-4 inhibitor use would also be associated with less severe outcomes in COVID-19. DPP-4 inhibitors probably have some of the same anti-inflammatory effects that metformin does. There are no hypotheses that sulfonylureas have similar anti-inflammatory actions in the setting of COVID. So the fact that these point estimates are just to the left of 1, and these point estimates are further to the left of 1, is consistent with what we would have guessed would happen. But it is reassuring that even compared to DPP-4 inhibitors, everything is on the same side of a relative risk of 1. And we also used a negative control to see if any association we found was just based on what we were adjusting for. And you can see that the negative control didn't change, and that's reassuring. And this table just has the numbers from this figure. We looked at the two cohort comparisons across pre-specified subgroups as well. So by gender, and then BMI less than 25, BMI greater than 25. And you can see overall things are still mostly to the left of 1. We were not entirely sure what to make of females and having a odds ratio greater than 1 for compared to DPP-4 inhibitors, but these are just subgroups analyses and just observational analyses. So going along the same time through the end of 2020 and throughout 2021, I was also conducting a phase 3 randomized clinical trial of metformin for early outpatient treatment of COVID-19. And so we enrolled our first patient about exactly 2 years ago. And so in the subsequent 13 months, we enrolled and randomized 1,400 adults to a treatment of metformin, fluvoxamine, or ivermectin. And I could give a whole hour-long talk about this trial, so I'll skip a lot of the details and kind of just jump to the results. But one point I wanted to make is that in summer 2021, when we submitted the observational analysis from the N3C, a few months later, we had our first pre-specified sample size recalculation for the trial. And Jared, the statistician on the team, also looked at the observational data as one of the data points he used when conducting the sample size recalculation. And then just very briefly, again, this could be a whole talk in and of itself. The clinical trial was a factorial design trial, so a 2x3 factorial design. But the main point to take away is that it's 3 separate trials for the price of 1. So everyone in the trial received metformin or exact matching metformin placebo. And often similar factorial design trials will publish the separate medications in separate papers so that they have enough room to fit all the secondary and post hoc analyses in the primary outcome paper. We did publish all the medications at once in one paper, but it really is 3 separate trials. And these are the results. So all of the numbers in this figure were published in August of this year. The primary outcome of the trial was whether or not any of the medications prevented hypoxia, ED visit, hospitalization, or death. The results that I'm going to focus on for the trial are metformin. I won't be talking about fluvoxamine or ivermectin. And the FDA gives guidance on sequentially removing components of a composite outcome that are least associated with severe disease. And the reason we have composite outcomes is because it's hard to power all trials to an endpoint of hospitalization or death. And the hypoxia component of the primary outcome had a lot of bias in it. After we started enrolling, the FDA put out a statement of warning about the accuracy of these home oximeters. And it did appear that the oxygen data had poor internal validity. But you can see as you sequentially remove the component of the composite outcome that are least associated with severe disease, the point estimate moves further and further left. And I won't get into this, but that was the case in both the modified intention to treat and the intention to treat populations. Last point I'll make is that the pre-specified primary analysis was with imputation. The top line is with imputation, the bottom line is complete case. And the missingness for the primary outcome was only 1.4%, which is why the imputed and complete case results are virtually the same. In addition to assessing severe COVID in the first 14 days from enrollment, we also followed patients for 10 months to assess whether or not they developed long COVID. And the way we assessed long COVID was to ask participants if a medical provider had told them that they have long COVID. And then we asked them what kind of provider gave them that diagnosis. So this way of ascertaining long COVID isn't perfect. But it did seem to be a good balance of sensitivity and specificity. There are factors that would influence whether or not someone was able to receive a diagnosis from a provider, a diagnosis of long COVID, but these factors would be equally distributed by the randomization in this randomized trial. And all forms of ascertaining long COVID are imperfect, as we're all trying to define it in the N3C as well. Symptoms may be lacking in specificity, relying purely on medical record diagnoses, may have low sensitivity or specificity. And this was a prospective sample that we enrolled and we were following prospectively. So I wanted to understand from this group, how often are they receiving a diagnosis of long COVID? And we could see how that compares to what we're finding in large databases like the N3C. So briefly, we added the long COVID outcome after the trial started because long COVID wasn't a known entity when we first started enrolling. So not all individuals were consented for this 10-month follow-up. So that's why this number is a little bit lower than the 1323. But overall, 8.4% responded that yes, they had received a diagnosis of long COVID from a medical provider. Most of these diagnoses were coming from primary care providers, some from long COVID specialists, and then a handful of other specialists made up the other sources of diagnoses. And then we also asked, among those who said yes, they had been diagnosed with long COVID, we also asked if they had received treatment for long COVID, and only 3.8% reported having received treatment for long COVID. And again, most of this was by primary care. And looking at the results for metformin compared to placebo, metformin did prevent the development of long COVID over 10-month follow-up. You can see the curves separate fairly early on, and this separation continues. And one of the advantages of showing a cumulative incidence like this is just to understand when people are receiving diagnoses of long COVID relative to when they were infected with the virus. And so this might come as a total surprise if you've not been in the niche world of metformin for COVID-19, but there are a number of other studies coming out looking at metformin against SARS-CoV-2. So this is data from a recent phase 2 randomized trial showing a dose-dependent response for metformin inhibiting the virus in vitro assays. And then another publication just came out showing more preclinical data of metformin inhibiting SARS-CoV-2. And then we also obtained viral load samples in our trial. We are analyzing this data now, but it also appears that metformin inhibited SARS-CoV-2 in our clinical trial. And it's hard, at least for me, to appreciate the magnitude of effect on log scales, but the magnitude of effect here is between molnupiravir and Paxlovid. And at day 10, it's larger than Paxlovid. And does this antiviral finding make sense as we look at our clinical outcomes? And I'm not a virologist or an infectious disease doctor, but my general understanding is that antiviral agents are thought to be more effective if started earlier on in the course of infection. And I show this slide just to show that in the pre-specified subgroup of individuals who started metformin within less than 4 days of symptom onset, the point estimate does move to the left compared to everyone in the trial, so including those who didn't start within 4 days of symptom onset. So that was true for preventing healthcare use during acute COVID, and also true for preventing long COVID. Again, you can see the point estimate moving to the left, which might be evidence to support this antiviral hypothesis of metformin against SARS-CoV-2. I still think that the anti-inflammatory actions of metformin are probably relevant as well. And this idea of having a dual acting medication is being pursued even in brand new therapeutics like sabizabulin. And then lastly, it'd be great if there were more trial data other than just our trial data. Everything I've shown up to this point is from our clinical trial. There was a smaller clinical trial much earlier in the pandemic, so pre-vaccination, pre-Delta, and they also used a high dose right from the beginning with no dose titration. And a lot of people will definitely get side effects from metformin without a dose titration. So the per protocol subgroup might be particularly informative from this trial. And they show a point estimate, in the range of the other point estimates in our trial. And then that phase 2 trial just published also has a similar point estimate, but the numbers are very small. But as I look at this from far away, all the big dots, all the point estimates are clearly in the same direction compared to 1. But, why would this make sense? Most people with diabetes, with type 2 diabetes, are on metformin, but we've been hearing a narrative, at least in the popular news media, that people with diabetes are experiencing mortality from COVID at a really high rate. So this was published in April 2021, saying that 30 to 40% of all coronavirus deaths have occurred among people with diabetes. Well, that is just about the prevalence of diabetes in older adults in the US, the group that's most susceptible to dying from COVID. And when you look at the sources that they referenced, the first was a very old report from the CDC in which the comorbidities were not known for most of the decedents. The second was a report that included multiple comorbidities, which all combined to account for 30% of COVID deaths. But when you read the report, only 8% was attributed to diabetes. And the third source was also not accurate. But diabetes is a risk factor for mortality from a number of infections. And looking at Medicare data, among those dying of influenza pre-COVID, over 45% have diabetes. So we would expect that a large number would have diabetes. So I think this is a weird analysis to think about, but when we're told things like this from the popular media, we have to think, is that different than any other infection? And could metformin actually be protective if a large percentage of individuals with diabetes are dying from COVID? Probably it is. So in summary, and I'll hand it over to Justin, I tried to very quickly go through in vitro data, in vivo data, observational data of metformin against SARS-CoV-2, as well as clinical trial data, most of which was from our clinical trial, which was conducted in the US. It included about 50% vaccinated, 50% unvaccinated. It included average, moderate, and high-risk adults. And we saw that metformin prevented the development of long COVID and prevented ED visits, hospitalizations, and death. Metformin is very safe, widely available, has few medication interactions. We had pregnant women in our trial, a small number, but I think these are all aspects of metformin that mean that further study is warranted. And stepping back from metformin and just thinking about long COVID, 8% of adults in our over 1,000 person trial had received a diagnosis of long COVID from a medical provider in the following 10 months. And only 4% of those had received treatment for long COVID. So we definitely need more treatments for long COVID. Thank you. I want to say thank you most importantly to a patient advisory panel that I meet with regularly. I started meeting with them before COVID, and they graciously pivoted and reviewed every aspect of the clinical trial I talked about. Thank you to the N3C, everyone who built that, and my collaborators on this N3C analysis. Over to Justin. And yes, Melissa, it was 8% with long COVID in all treatment groups, everyone in the trial.
Great, thank you.
You're on mute, Justin.
Thank you. Okay. Some quick disclosures, some grants to acknowledge, no financial disclosures. So yeah, following up from what Carolyn said, I wanted to say a couple of words about how we came to collaborate. This collaboration with Carolyn came about after we gave we presented some results on our GraphML results, which I'll tell you about in a minute. And Carolyn asked about whether we were able to find any signal to do with metformin, and actually we had, and so we decided to collaborate. I'll give you a little bit of background on what the GraphML results were and why that sort of fostered this collaboration with Carolyn. If you don't know, okay, so first, if you don't know what a knowledge graph is, I'll give you a little primer here. Basically, it's very simple. You have entities, those are people, places, genes, diseases, those are nodes in a graph, and the relationships are edges between the graphs. So here you have Steve Jobs, who's a fan of Bob Dylan, who created Highway 61. This is a really nice way of richly representing complex data that you find in biomedicine and also a lot of other different fields. This is good for a bunch of different things, but what we were particularly interested in using it for was GraphML to extract knowledge specifically about what drugs might have some effect on COVID-19 outcome, either positive or negative, I should say. And so we constructed KG COVID-19. That's what it sounds like. It's a knowledge graph that integrates COVID-19 data. We published a paper on it here if you're interested. I think we're going to share these slides. But as I said, the purpose for this was to do machine learning on the knowledge graph to find drugs that will have some effect on COVID-19 outcome. And to do that, we integrated data from 18 different sources, integrated about 24 million relationships between about 500,000 things. This included 4 different drug databases, all known human diseases, human phenotypes, gene functions, chemicals, protein-protein interactions, protein pathways, and some scientific literature. And so this is kind of just the knowledge graph, the sort of raw substrate. So how do you actually do graph machine learning to actually identify drugs that might be useful? So you start with a knowledge graph. We applied an algorithm called node-to-vec, which creates what are called embeddings. Basically, it takes every node in the knowledge graph and transforms it into a low-dimensional space, and it kind of captures all the information that you have about each of those entities. And so things that end up close in space are more related to each other. Things that are far away are less related to each other. And so there's a node in here that represents SARS-CoV-2. We have basically all known drugs in here too. And so basically we're transforming this knowledge graph into a space where proximity of these drugs to SARS-CoV-2 means that they might have something to do with SARS-CoV-2 and therefore might have some effect on outcome. And so if you do all this and then you look at drugs that are basically every single known drug and its proximity to SARS-CoV-2, you see this sort of random signal, sort of some Gaussian noise. And then off to the right here, you see 500 or so drugs that are close in latent space to SARS-CoV-2. So these would be the good drug repurposing candidates. The themes in here, I can actually share this list if anybody's interested in the gory details, but the themes among these top 500 drugs makes a lot of sense. Steroid drugs, antivirals, NSAIDs. We actually published a paper after having done a deep dive on this and the effect of these on COVID-19. SSRIs made the list, and after a discussion with Carolyn, she asked us where metformin was in this list, and sure enough, it was off on the right here among these drugs. It was ranked 505 among about 6,900 drugs that Kemble identified as having some sort of antiviral activity. And so we decided to collaborate with Carolyn on this. In connection with this, and sort of as the next phase of our GraphML experiments, we also built an observational retrospective pipeline to evaluate our drug candidates. We've actually used it for a few other things, the psychiatric sequelae paper you can see here, and the NSAID paper, which you can read more about. So the idea here was to apply this pipeline to Metformin and also do it in a way that was in spirit the same as what Carolyn described, but a different software stack, a different implementation of the observational pipeline. So sort of independent corroboration of the sorts of things that Carolyn observed. So Carolyn told you her analysis, at least some of it was in diabetic patients, and she proved pretty convincingly that metformin use was associated with less severe COVID-19 and improved outcome. So the idea here was to analyze this in patients without diabetes. And so if the cohorts that are available and feasible for which to do this study are basically those who are taking metformin off-label, because metformin is only approved, as far as I know, for diabetes. So there are two groups of people who frequently take metformin off-label. Those would be people with pre-diabetes and people with PCOS. So this is together a very large group of people. Pre-diabetes is depressingly common. About 96 million people have it in North America. This is 38% of the adult US population. Polycystic ovary syndrome is less common, but still very common, 6 to 12% of US women of reproductive age. And insulin resistance is a frequent comorbidity of PCOS. And so metformin is frequently prescribed for this and for used off-label for PCOS and pre-diabetes. So this gives us a large number of patients that we can do the observational study on. So here is a consort diagram of how we constructed the cohorts. We start off by excluding anyone with any record of any type of diabetes. The idea here is to compare COVID-19 severity among metformin users and compare them to a comparator drug. We used two different comparator drugs. The first was levothyroxine. That's nothing to do with diabetes or glycemic control. This is but it is prescription. It's taken daily, and it's typically taken for long term, not just for a couple of days. And so it's a decent comparative drug. The other is ondansetron. This is an anti-nausea drug. This has some limitations, since it's typically given either after surgery or during chemo. So there's some possible confounding there that we think we've controlled for. Ideally, we would use, obviously, anti-hyperglycemic drugs, and we tried very hard to find sufficient numbers, but we're unable to do so. So these are sort of we think the best comparative drugs we could use. So use here for all of these drugs is defined as recorded use during COVID presentation. The outcome we're looking at here is WHO COVID-19 severity. This is an ordinal variable from 1 to 4 that basically describes how bad your COVID is. A bit about the statistical model. There's a lot of missingness. I probably don't have to tell anyone in this call, that especially with BMI. So Elena Kasaragi and Lauren Chan wrote some very nice software to impute missingness. We used propensity weighting to align the treatment group with either the controls that were used. That again was Elena and Lauren. The outcome here was COVID severity as a binary variable. I told you before that the severity is on a scale from 1 to 5. So We treat this as a binary variable into several logistic regressions. So COVID severity greater than 2, that's one binary variable. A different outcome, COVID-19 severity greater than 3 or greater than 4. We remove collinear covariates using GIF. That again was Elena's handiwork. And so to actually measure the effect, we used a logistic regression. Our predictors were metformin or versus the comparator drug, 12 different comorbidities, age, BMI, demographic, race, and ethnicity data. So here are the point estimates. You can see, as with Carolyn's data, all of the point estimates are less than 1, meaning this is an association with less severe COVID. So I've outlined, we did, as I said, a number of different logistic regressions here. In the pre-DM cohort, I'm showing you the significant associations here. Metformin versus levothyroxine was significant with a COVID-19 outcome of mild ED or worse, or moderate or worse. Compared to ondansetron, all outcomes were significantly different. In other words, metformin always helped. In the PCOS cohort, we only saw a significant result of metformin versus ondansetron for mild ED or worse than moderate or worse. I should also point out there are very few people in the PCOS cohort with very bad outcomes. So I don't think we had any, we didn't have sufficient numbers of COVID-19 severity of 4 or 5 to do that experiment. A few limitations, I think Carolyn brought these up. These are observational retrospective studies. They're subject to confounding, and also the data on which we've done them is incompletely captured. A bit about the comparator drugs. Obviously, anti-hyperglycemics would have been a better comparator drug here, but they weren't available in sufficient numbers. I mentioned before, ondansetron is probably not the ideal comparator, but because it's frequently prescribed after surgery or during chemotherapy. I'll point out, though, we did balance for cancer and many other comorbidities. Another note, I think Carolyn had some data around this, but our design can't really make any statement about when metformin might be helping, if this is a real effect that we're seeing. So PCS has a very high overlap with pre-DM. In other words, a lot of people with PCOS also have pre-DM. So it might take some more research to tease out the actual relationship. Carolyn also mentioned some leads that could be followed up as far as the mechanism of action. In other words, what is causing this effect or this association. And the nature of the effect with respect to diabetes and pre-diabetes. Some people to acknowledge: the coffee hackathons, especially Lauren Chan, our wonderful graduate student, Elena Casaraghi, our colleague in Italy, the rest of the group. It's been a pleasure to collaborate with Carolyn and the diabetes domain team, John Buse, Till Sturmer, Adnan Zaman, Melissa Handel, and all the other N3C colleagues, and the N3C community at large, which is just a great way to assemble these sort of self-organizing, inclusive working groups. And we think we've gotten a lot done. We can probably turn it over for questions.
Are there any questions? Now, there were some questions answered in the Q&A.
Yeah, I have a question for you guys, and one really great work. I appreciate seeing this. So Carolyn and Justin, thank you for the work and also for presenting. And this is at NCATS, we do quite a bit of preclinical work, and obviously worked quite a bit with mTOR inhibitors in the cancer space. So not surprising at all, Carolyn, we gave that background there. Have you guys done any models, not to get added complexity, but with combination screening? And I'm not focusing just on COVID, but just, and I'm wondering if this is more a question for Justin on some of these, because that's obviously very prevalent in the cancer therapy space, and we do quite a bit of work with preclinical assays, not necessarily clinical trials. So I was curious if you guys have actually tried to also enhance your model potentially with potential combinations.
Combinations of drugs?
Of drugs, yeah, I'm sorry, Justin, yeah, combinations of different drugs.
I don't have any, I've not done any experiments to look into that. That's an interesting idea though. But Carolyn, have you done anything like that?
No, I haven't. Is it good?
Just something to consider, again, and not to add additional complexity, but it was, it'd be really cool, cool to talk about potentially offline on, because what we look for essentially are starting in silico, like you guys did, do predictive, and then in this case, test assay systems against it. And we do that quite a bit of combination. We do a lot of this in collaboration with NCI. And we've had a lot of success, and we're always looking for different models, but really I just want to comment, really, really beautiful work. Thank you guys so much for presenting.
Yeah, I'm sure David Odie, my collaborator who does the in silico modeling, would love to talk to you about that. But yeah.
Yeah, let's talk offline, Sam.
Yes, and good job, Lauren, for all of her work and awards for this work. And Harold,
Justin.
I don't know why. It's a good question that I just typed a response to, but the primary outcome of the trial was negative. And how that is interpreted and whether it's appropriate to interpret only the primary outcome is an important question.
This is Ken again. Great work. Quick question, and Justin, I wanted to ask about the other oral hypoglycemics. They're very common, and could you give us more detail of why you weren't able to find enough folks?
Well,
or Carolyn, yeah.
yeah, he was excluding people with type 2 diabetes, and those other oral hypoglycemics are not prescribed in people with PCOS or prediabetes.
I see. Okay.
Yeah, so we would not. It'd be problematic if we saw a lot of sulfonylureas prescribed to people with PCOS or prediabetes.
Yes. Thank you. Nice job, guys.
But it is getting a little bit hard to tease out. The GLP-1 receptor agonists are now used often for treating obesity and for weight loss in the absence of diabetes or prediabetes or PCOS. So it's not necessarily the case that you can define a diabetes phenotype just based on therapeutics for diabetes. So.
Yes.
I don't know, Harold, you tell me why metformin is not standard of care. Any, one of the, I'm really asking, so, I guess if it isn't, Harold, I'm seeing your next question. It's my fault. It's sort of on me to advance all these papers. The next one that we're working on is our viral load analysis, and I had to figure out funding to do that. But we will be submitting that as a preprint very soon, I hope, and potentially once we have that and that viral load data, that might be a convincing next step in the data for people to understand the mechanism, because it's not an obvious mechanism why metformin would work. So we're trying to get that out soon, and then But it is an IND, FDA regulated trial. I obtained an IND before starting the trial as well. I'll say one thing, we did not obtain glucose measurements. You do not need to check glucose after starting metformin. It does not lower glucose below a physiologic level, so it doesn't cause hypoglycemia. So we did have a BMI minimum for being in the trial of 25, so probably many people with a BMI over 25 have some degree of insulin resistance, but even if someone had a normal BMI, you would not have to check glucose after starting metformin.
Are there any more questions? I don't see any of the attendees. Asking questions. So I guess if there are no other questions, great work. It's great to see, sort of something shown from multiple angles, right? From clinical trials, from observational data, and seeing the signal preserved across all these multiple types of research, which is nice.
And I hope the clinical trial data could be a gut check on the observational data for the long COVID diagnosis, since we asked the 1,100 participants in the trial, have you been diagnosed? So in theory, that's a large enough sample that it should come close to what we see in the N3C, but of course we're all learning, and all of these sources of data have some bias.
Yeah, and I think there's a lot of questions, at least in Recover, on sort of the definition of long COVID, right? So it's nice to have from this external source. So definitely interesting.
Mm-hmm. Yeah,
So-
Melissa, happy to help. Yeah. Mm-hmm. Thanks everyone for having us.
Thank you.
Congratulations.